Very good morning. Today we are discussing on salivary gland disorders. So, as we know, oral cavity has got salivary glands that is called as a major salivary gland and the minor salivary glands. We have two pairs of major salivary glands, that is the submandibular and the parotid. Three pairs of major salivary glands, that is submandibular, sublingual, and the parotid glands. And we have n number of minor salivary glands which supplies frequently and constantly to provide the moist environment in the oral cavity, which provides the sufficient lubrications to the oral structures and which provides the salivary flow adequately. So any diseases affecting these glands will adversely affect the functions of the saliva, that is being the protection of the oral mucosa, prevention of the dental caries, maintaining protection from the various infections affecting the teeth and the mucosal structures, etc. So broadly, the salivary gland diseases can be classified as developmental anomalies, reactive and obstructive disorders, functional disorders, infections, immune-mediated disorders, and neoplastic diseases affecting the glands. The developmental disorders mainly includes the aplasia and hyperplasia of the glands, the aberrancy of the glands, accessory ducts, diverticuli, hyperplasia, and the congenital fistula. Under the reactive and obstructive disorders, we have mucocele, granular silolithiasis, the chronic sclerosing silodenitis, necrotizing silometaplasia, and cheilitis glandularis. The functional diseases includes the siluria and the xerostomia. The infections includes bacterial infections, viral infections. Under the bacterial infections, we have the acute, chronic, and the recurrent infections. We have the tubercular infections, Castrar disease. Under the viral infections, we have mumps, cytomegaloviral infections, and the HIV-related salivary gland infection. The immune-mediated disorders affecting the glands include Sjogren's syndrome, Mikulicz disease, allergic silodenitis, amyloidosis, SLE, etc. The neoplastic disorders includes benign and malignant disorders. Under the benign, we have the pleomorphic adenoma, monomorphic adenoma, Warthin's tumor, oncocytoma, and we have the malignant version of the pleomorphic adenomas. We have adenoid cystic carcinoma, acinic cell carcinoma, etc. So these classifications are purely based on the etiology of the disease and the nature of the disease. Coming to the individual description of the salivary gland disorders, mainly the developmental anomalies, we have the salivary gland aplasia, which is nothing but incomplete formation or hypoplasia or agenesis of one gland or multiple glands. Usually the developmental anomaly with the deficiency or agenesis of the gland is purely a rare condition which may be seen associated with other malformations of the first branchial arch, wherein there will be multiple deficiencies or multiple developmental discrepancy involving the first branchial arch. When the gland is partly formed or incompletely formed, most of the time it might remain asymptomatic because the remaining glands or the other glands will compensate the function of the missing gland. Some patients may develop hyposalivation leading to xerostomia, dryness. The complications related to xerostomia, including dryness, burning sensation, increased caries rate, and things like that. The rest of the patients will remain totally asymptomatic. Aberrancy is another development anomaly wherein the salivary glands are seen at an unusual anatomic site. So histologically and clinically, this tissue will be similar to the salivary gland with the normal acini and the parenchyma, etc. But the lesion will be in an abnormal anatomic site. For example, the gland will be seen in the middle ear, the external auditory canal, the neck, the posterior part of the mandible, the anterior mandible, in the pituitary fossa, etc. So this will be usually doesn't create any abnormal clinical presentation, but they are incidentally identified during surgery, during MRI scanning, or during some other investigations. One common aberrant salivary gland that we might encounter is a Staphy's cyst. So Staphy's cyst is actually a false cyst in which there is a cystic-like pathology seen in the mandible when taken, when a CBCT or a OPG is taken. Especially in an OPG, it will look like a cystic lesion. This is created by an unusual or exaggerated salivary gland tissue that compresses against the lingual aspect of the body of the mandible. And because of the exaggerated or aberrant tissue, there is a depression created on the lingual side of the mandibular body, creating a cyst-like appearance on a radiogram. So that is one example for aberrant salivary gland. Then we have accessory ducts. These are conditions where there is additional salivary gland ducts are developed without any clinical significance or without any non-etiology. These are common usually and they remain usually unidentified and they do not require any treatment. These are identified on careful examination or during some evaluation for any pathology or during some surgery or things like that. This usually involves a parotid gland. Apart from the normal Stensen's duct of the gland, which opens against the buccal mucosa of the maxillary second molar region, there will be one additional duct form seen over there, just superior and anterior to the normal opening of the Stensen's duct. Another development anomaly related to the gland is a diverticulum. Diverticulum is an abnormal pouch or a sac that is produced from the wall of the duct. So this could be an abnormal pouching where there is a pooling of the saliva. So this recurrent, this abnormal pouch or a space over there will lead to a collection of saliva in that region, pooling of saliva in that region. This will predispose to recurrent infections in the gland or silentinitis of the gland. So these patients should be given instructions to prevent the infections like frequent milking of the salivary gland or drinking of water or stimulation of the gland, etc. so that the pooling or collection of saliva can be prevented. Another development anomaly is hyperplasia, which involves mainly the minor salivary glands. This happens between 4th and 6th decades of life, where there will be localized enlargement of the minor salivary gland, which might clinically resemble like benign neoplasm, benign growths, or even mucoceles and etc. These are usually painless swellings in the palate or in the mucosa, which will be soft, firm on palpation, doesn't create any clinical symptom except just a discomfort or a feeling of swelling to the patient. On palpation, it will look like a soft fluctuant swelling, like a mucosal or a fibroma or things like that. So this, if it is interfering the function or discomfort, creating a discomfort, it could be excised. Sometimes it is removed for to confirm to be to differentiate it from a benign or malignant growth. It can be biopsied and histologically verified. Coming to the of reactive lesions, we have the mucocele, which is caused swelling of the lips, which is caused by accumulation of saliva from a traumatized or obstructed minor salivary gland duct. So the minor salivary glands and its related ducts may get traumatized or injured during a trauma, biting, or during some other fall or a domestic injury or anything like that, leading to pooling of the saliva in the tissue. So this will create a phenomenon called as mucous retention phenomenon or a extravasation phenomenon. Extravasation means the fluid is leaking from the duct into the surrounding tissue. That is extra means outside, vessel means vessel. Whereas in retention type of mucocele, there is a block in the ductal opening and pooling of saliva within the salivary gland tissue or the ductal system. Okay. So as you see in the picture, mucocele, the first one shows the extravasation type and the second one shows the retention type. So usually mucocele is seen in the children and young adults, usually involving the lower lip. It is clinically soft, fluctuant, dome-shaped swelling of 2 millimeters to up to 1 centimeter. If it is superficial, it will have a bluish translucent color. If it is deeper, it will have a normal mucosal color. And usually the patient will have an intermittent nature because this mucosal have a tendency to rupture and empty. Then it might reappear after a few weeks or few days, and it has to be differentiated from other neoplasm, vascular lesions, and vesicular lesions. So as you see here, different types of mucosal can be seen here. The keratotic surface, if it is chronic, if it is superficial, it will be very bluish color and dome shape like this, very typical in nature, like this. So simple surgical excision is sufficient. Along with the excision, we have to remove the other related minor salivary. Next obstructive lesion is a ranula, which is a type of mucosal which is occurring in the floor of mouth. This is associated with the submandibular and the sublingual gland duct, and the name ranula comes from the terminology. Rana means frog. So the swelling will appear clinically like the belly of a frog. It has got a dome-shaped, fluctuant, bluish swelling. If it is larger, it will elevate the tongue, and sometimes it will herniate through the mylohyoid muscle in the floor of mouth and go to the neck, giving to a midline neck swelling. Okay, so this is the clinical appearance of the ranula. You can see a swelling in the floor of mouth, extending to the neck, sometimes lifting the tongue, causing discomfort to the patient to speech and chew the food. So that is the reactive and the obstructive disease affecting the gland.